Welcome to AETCM, the Emergency Medicine channel. Madam, 8-year-old female child came to our ER with a history of fever since 2 days, associated with cough, breathlessness since 1 day.
Okay.
For initial 10-second assessment by PAT triangle, on appearance-wise, child is active, alert, interacting normally, tone-wise appear normal. And work of breathing, in appearance patient is tachypneic. So there is no use of any secondary accessory muscles of respiration. Circulation part, there is no cyanosis, no pallor or no mottling. And primary survey, airway was patent.
So, what was the abnormality you saw in the PAT triangle?
PAT triangle patient is tachypneic, is suggestive of a respiratory system feeling.
Was she using any accessory muscles?
No use of accessory muscles.
What all will you check? Accessory muscle use.
First of all, neck muscles, use of neck muscles.
First of all, from the nose.
Flaring of LA of Nasi, then use of neck muscles like sternocleidomastoid muscles, scalene muscles, and chest-wise, chest indrawing, external intercostal muscle indrawing, chest retractions, chest movements also, fast movements of chest.
So normally during inspiration, which all muscles do we use?
External intercostal muscles we use.
And? Diaphragm. Usually during inspiration we use the external intercostal muscles and diaphragm. Expiration?
Passive. Normal
expiration is a passive process, so we are not using any muscles. So in case of respiratory distress, only we will be using the internal intercostal muscles, the abdominal muscles, and also the neck muscles, either scalenes and sternocleidomastoid. Then air of the nose, everything will start moving. Okay. So that was seen. So that was the abnormality you saw.
Triangle.
Circulation was
no cyanosis. No.
Okay.
Primary survey, airway was patent. There is no added sounds. Breathing part, respiratory rate is 34 per minute. Saturation is 96% saturation room air. On auscultation, bilateral V is present. Bilateral equal air entry.
Okay, so respiratory rate is
34.
34. What is a normal respiratory rate we are expecting in this age?
Infant, there is respiratory rate is 30 to 60. Then it becomes decreases
so,
when age increases.
Infant, especially less than 2 months, more than 60 is considered as tachypnea.
Then 2 to 12 months, more than 50, like 1 to 5 years, more than 40 tachypnea considered. In that 6 to 12 years, normal respiratory rate is 18 to 30. So mild tachypneic is 34.
Child is tachypneic, okay.
Circulation part, BP is 90-60, heart rate is 110 per minute, CRT is less than 2 seconds. Disability part, GCS is full and pupils bilateral equally reactive. Exposure part, temperature is 104 degree Fahrenheit and weight is 30 kg. Adjoint to
so was the child able to talk in one full sentence?
Yes.
Okay. So based on the primary survey, how can we classify the type of asthma this child is having?
Normally mild, moderate. This by
mild,
child
moderate, severe. Is by which classification?
Global Initiative of Asthma GNA classification. In this child, it is mild asthma is.
Mild asthma. Okay, so we have another classification for pediatric respiratory assessment measure. That classification is there. So in that classification, they will be mainly checking for the use of accessory muscles, like use of any scalene muscles, use of any other supraclavicular muscles. Then the oxygen saturation. So use of neck muscles, 2 score will come. Then use of any neck, saturation of the child, then air entry of the child, and any other added sounds like wheezing. So 5 points are checked in this, and based on the score we can classify into mild, moderate and severe. Okay, so mild means score from up to 3 is mild, 4 to 7 is moderate, and from 8 to 12 maximum score is 12. So 8 to 12 it is coming as severe. Okay, so based on that we can classify, or we can classify based on the UK guidelines also you can classify. So this child is coming as mild. Okay, so what will you do now?
Fever 101 degree, so we give paracetamol as per weightage. 15 milligram per kilogram is the dosage. Then there is bilateral VCs also there. So we start on nebulization.
What paracetamol was given, oral or IV?
Oral tablet, 500 mg paracetamol is given. 450 mg is the dose of 400 mg, 500 mg was given. Then for bilateral VCs present, then start on nebulization with salbutamol. Salbutamol pediatric dose is 0.15 mg per kg per dose. That is for 2 to 4 cycles. We'll repeat intermittently with every interval of 20 minutes.
So you have given nebulization. What else can be given other than if nebulization is not available?
No, then also we can IV methylprednisolone also we can given.
No, this patient is coming as mild only. Mild cases we just have to give only salbutamol. In moderate cases we can give salbutamol along with steroids, and severe cases we can give salbutamol, steroid and ipratropium. So salbutamol you have given. If nebulization is not available, you can use
inhalers.
Meter dose inhalers can be used. So how will you use meter dose inhalers? With spacer. So how, if suppose a child doesn't know how to use, how will you teach them to use?
Spacer kept on mouthpiece kept on the mouth and hold for 10 seconds.
So usually in adult it will be coming in a L shape. So when we push down the canister, patient has to simultaneously take breath. So we will be removing the cap, we will be cleaning that portion, and we will have to ask the patient to take normal breath and to expire all the air out. After expiring all the air out, still ask the patient to whatever is in the mouth, ask them to pull it out like that. So all air should go out. Then ask the patient to take a breath, not like a fast breath, a normal breath. That time it should be pushed and the breath should be taken. That is how we normally use a meter dose inhaler. Whereas if we don't have that, and if it is a child, it will be very difficult for us to synchronize that. So in case of child, we can use a spacer. So while spacer can be used, and spacer with the mask, sometimes the child won't be able to hold on to that spacer device. So instead of that, towards the end of the spacer we can attach a mask also. So that can be kept in child's mouth, and we can press on it and allow the child to take 8 to 10 breaths after pressing onto the canister. Then only it will be delivered. And after giving the meter dose inhaler, what should you ask? Wash the mouth. Otherwise there will be oral candidiasis will there. Okay. So nebulization you have advised.
Then if the breathing difficulty doesn't improving,
if it is not settling only, we will be planning on going to the next management. Okay.
Also chest investigation part, chest x-ray, fever also is there, 1 day history of, and cough also is there, so that with breathing difficulty. So chest x-ray and ABG also taken as adjuvant.
Is it necessary? What are you expecting in chest x-ray?
Any infection also is.
When all will you consider taking chest x-ray in a case of bronchial asthma?
Impending respiratory failure or complications in.
Like what are you looking in that x-ray? Consolidation you can look.
Collapse, consolidation.
Consolidation and or pneumothorax. If you are suspecting that only, go for an x-ray. That too in case of life-threatening asthma only an x-ray is indicated. Otherwise unnecessarily don't do an x-ray. You can check the counts, and ABG also only in life-threatening situations we will be doing such things. Okay. And anything was else?
if the
So I think for adjuncts, in this patient, adjuncts whatever required is we can give paracetamol to the child, and we can give nebulization salbutamol, and we can reassess after 20 minutes. Within that time you can take the sample history also. The rest of the things are not required at present. Okay.
Sample history, 80-year-old female, known case of bronchial asthma, child had intermittent high-grade fever since 2 days, followed by a patient had a history of cough and associated with breathing difficulty, which was progressively worsening since 1 day. Allergic history, patient allergic to dust allergy. Medication history, patient was taking metered-dose inhaler, Astalin 100 microgram and Budicort 200 microgram. Past history, similar history 6 months back, and full-time firstborn child of non-consensual marriage and fully vaccinated as per national immunization schedule and developmentally normal child.
Okay.
General examination is active and alert. Respiratory system examination, bilateral equal air entry to bilateral V's %. Other system within normal limits.
What was your impression?
Infective exacerbation of bronchial asthma.
What else was done? So this patient already X-ray was done. What was X-ray finding?
X-ray.
Was normal only. Okay, then counts and all, anything was done?
Count 12,000, CRP is 8 and platelet is 2 lakh.
Okay. Then what was done to the patient then?
Then
Was the child admitted or
no, madam, after nebulization,
child improved
improved.
and was discharged?
Discharged.
Okay. So we have discussed about in an ER when a patient comes, after doing the PAT triangle, directly go into the primary survey. Based on the primary survey, we can classify the child based on the PRAM assessment which I have told, mild, moderate and severe. And in case of mild cases, only nebulization with salbutamol required. Moderate, salbutamol with steroids, and severe you can give salbutamol, steroid and ipratropium bromide. Or else we can classify the children based on the European scoring can be done. So that we can divide it into 4. Either you can mark the child as moderate asthma, or it can be acute severe asthma, or life-threatening asthma, or near fatal asthma. Okay. So based on the moderate asthma means we will be usually classifying it based on the PEFR percentage, but that is very difficult to check in our ER. So moderate asthma means patient will be having a normal saturation with the PEFR between 50 more than 50%. Okay, these might be there, this thing might be there. Then next is acute severe asthma. In acute severe asthma also the child's PFR might be less than 50%, but what is PFR?
Peak flow rate.
Peak expiratory flow rate. That might be less than 50%, but saturation might be normal. It will be anyway more than 92%. But the problem is the child, even though the saturation is maintained, what other things can happen? Won't be able to talk in one full sentence, or the child might be having some tachycardia might be there, or the child's respiratory rate will be more than 25. So a heart rate more than 110 and a respiratory rate more than 25. This is in case of adults only. In children, depending on the age, we will classify. And so that is there, that is called as acute severe asthma. Then next is the life-threatening asthma. So from acute severe asthma, when will you call if it is life-threatening?
There is impending respiratory failures like change in level of sensorium, cyanosis, PCO2 buildup.
No, PCO2 buildup will come into fatal asthma. So in first 2 we told saturation is maintained. It will be more than 92%. So one thing will be desaturation. So saturation less than 92% will be there. Then as you told, altered sensorium. Then cyanosis can be there. Then so in the second classification, that means in case of acute severe, I told respiratory rate more than 25 and heart rate more than 110. Whereas when we come to this one, whereas we come to life threatening, we will be seeing the patient going to hypotension. Hypotension might be there, or there can be arrhythmias also because of the respiratory distress. Arrhythmias can be there. or as I told, cyanosis and altered sensorium might be there for this individuals. So we need to intervene as early as possible in this patient. Or if you are not intervening, this patient will go into fatal asthma. Fatal asthma means requirement for intubation will be there and PCO2 buildup will be there. So usually asthma, what kind of respiratory failure are you expecting? Type 1 respiratory failure. So if type 1 is going to type 2, that is near fatal. Okay. So so initial management for all patients is bronchodilators. So in case of moderate asthma and also acute severe asthma, main stay of treatment is bronchodilators. And as it worsens only, we will be planning on giving ipratropium bromide, then steroids, then only rest of the things will come. Okay, so salbutamol. We told 2 ways we can give. Either meter dose inhalers can be given or nebulizations can be given. Okay, so meter dose inhaler salbutamol, how much will be delivered with each puff? If it is salbutamol, mostly 100 microgram will be given in one puff. Okay, so in case of so according to age, we need to give the puffs to the child. Okay, so if it is like the child's age is coming between up to 3 years, we will have to give only 4 puffs. Okay, up to 6 years you can give 6 puffs, and more than that, more than 7 years, you can give up to 8 puffs. So 4, 6, 8. So up to 3 years 4 puffs, up to 6 years 6 puffs, and more than that you can give 8 puffs. Okay, that will deliver 100 microgram of salbutamol. Whereas if you are using the nebulization, how is the salbutamol nebulization available?
0.03 ml per kg per dose is maximum 5 mg.
So 5 mg per ml is the dose available. So if the child's age is between 1 to 3 years and all, you can take 1/4 1/4 of that 1/4 ml, and we can add in 3 ml NS and we can give as nebulization. Then from 3 years to 6 years, you can give half ml with 3 ml NS. And if it is more than 7 years, you can take 1 ml in 3 ml NS and give nebulization. So net it will be delivering. So if it is like, if you are taking 1/4, it will almost deliver 1.25 mg will be delivered. 1.25 mg in 3 ml NS. And from 3 to 6 years, we will be child will be getting approximately 2.5 mg and 5 mg for more than 7 years. That is the dose. That is a dose of salbutamol. Okay, and if the child is not responding, then we can consider ipratropium. So what is the dose of ipratropium?
Less than or equal to 20 kg, 250 microgram per dose. More than 20 kg, 500 microgram per dose.
Can be given. So if it is like a puff, how much will be delivered?
500. Same 250.
Most nebulization is the one which I have told, 250 and 500. If it is puff, it is mostly only 20 to 30 microgram will be delivered. So we will have to give more puffs. Otherwise, you can give nebulization. With the nebulization, if you are giving, you will be able to deliver it as early as possible. Is there any difference in any advantage or disadvantage, or any difference in drug delivery if you are using nebulization or metered dose inhalers?
Metered dose inhaler, some drugs is settled in the device also. So
only thing is, if it is a child, it might be difficult to deliver with the metered dose inhaler, but the efficiency is same for both. Okay. So we have discussed about salbutamol and ipratropium bromide. Then when you are coming to steroid, what is the steroid which you will choose?
Methylprednisolone.
Can we choose? So what is the dose?
1 milligram per kilogram. Maximum 125 milligram.
Okay, that is IV or oral?
IV.
IV. Oral? IV you can give 1 mg per kg. Oral you can give 2 mg per kg. Okay. So IV when you are giving, you will be mostly giving methylprednisolone. Orally you are giving prednisolone. So prednisolone 2 mg per kg and methylprednisolone IV 1 mg per kg can be given. Okay. What is the other medications which you use?
IV MGSO4 can also use, that is 52
What is the use of giving magnesium sulfate?
bronchodilator action.
Okay.
If persisting asthma is there, we can give MGSO4 50 to 75 mg per kg over 20 minutes, maximum 2 gram,
So it should be diluted with
and 500 ml.
100 ml NS, and it should be given slowly over
20
minutes. Other drugs which can be given? One induction
Ketamine is, bronchodilator action is there.
is also there for ketamine. So if at all you are planning to intubate a patient, you can use as an induction agent, or if the patient is in severe distress also, for bronchodilator action, you can give lower dose IV ketamine.
Adrenaline also we can use by nebulization. Dose is 0.05 mg. Nebulization dose we can use.
So adrenaline also, when we are giving, that is also having a bronchodilatory property. Then if the patient is not responding to that only, then we will consider giving NIV and rest of it. Even after giving the nebulization, if the patient is failing, patient still having respiratory distress, then we will go for NIV supports. So why we are giving steroids?
Anti-inflammatory action.
And inflammatory action is there, and another thing is that steroid will take at least 6 hours to act.
Prevent the.
So we are trying to prevent the
recurrence.
That's the major. That's a major goal for giving steroids. Okay. Anything else? Okay. Thank you.